Here. I feel like that all of you individually are in rural communities because of the love of nature and that connectivity we have to our bodies and to our spirit and to our mind. Um, so what I prepared today is a little bit of a talk, and then there's a video in there as well to
Uh-oh. Did everybody freeze or just
the
me?
gaps we have and how we can network and how we can educate. And then, yeah, what are we taking away and what's the next action? That's pretty much the flow of it. So is that okay with everybody? And then we can have maybe like a question and answer section too. It depends on the time, I imagine. All right. So let me just share this here. You guys hear this? So recording stop.
Oh, there we
Uh,
go. We're good to go.
Okay, hold on a second. Let me just go back here. Oh. There you go. There we go. So I'm here today to advocate for a transformative approach to healthcare in our rural communities, community acupuncture. I believe this model isn't just an alternative, it's a vital component that should be fully integrated into our public healthcare system. By doing so, we can effectively dismantle some of the most persistent barriers to care and ensure that fundamental service of traditional Chinese medicine is available to all, regardless of their financial situation. Here in Kaslo, we have integrated a bi-weekly community acupuncture clinic governed by our nonprofit organization and charity called Kaslo Community Acupuncture Society, a privately funded organization. Now, since 2022, we have offered over 1,800 treatments to 360 individual patients. And remember, Kaslo only has 1,000 people. And the result of health improvements are astonishing. In general, we treat between 10 to 18 patients in 4 hours with 2 to 3 practitioners 26 times a year. In addition, we dispatched 2 wildlife trauma response clinics when we had the big fire in Argenta and 2 community trauma response, sorry, and 2 trauma response clinics. One was when we had like a horrible suicide death in our community and everybody was affected. And the other one was just last winter when we had an avalanche accident and one of our community members was part of the accident. Now, I have a little video that I would like to share, if that is okay. And it's just a 5-minute video, but it gives you a little bit of an idea on what we do in Kaslo. Community acupuncture made sense, and also it allows for people to heal together, which is, I think, a very powerful way of working as a community and existing as a community. So the reason why I started to consider community acupuncture clinic and starting the society was because I really saw the need for patients in Kaslo to receive community acupuncture for a way where they can be treated barrier-free, where financial challenges are not a problem, where they can come anytime they choose to, where they can heal in a group. And I just saw that in my clinic, by being a private practitioner, they just couldn't afford the care that they needed. So essentially, Alini and I took the community acupuncture model, which is a model in which there are many people in a clinic room being treated at the same time in reclining chairs.
That way we can treat a larger number of people per hour than in a private clinic. So we took this model and created a nonprofit society so that we would then have access to public funds. So we wouldn't have to charge a strict fee for our services, and that people could really just pay by donation and could really pay what they can afford. And in this way, our hope is to become a public service and have this be a totally barrier-free service where people do not have to pay anything and that we are 100% publicly funded. And this is a really easy model to create in a small community. And it's really cost effective and it reaches a lot of people and it changes a lot of people's lives.
A clinic like this is accessible to everyone because it is barrier free, which in my opinion means it doesn't matter if you can afford it or not. We want you to come and receive treatment. It's such a beautiful thing to watch people intentionally come in to take care of themselves and sit in a room with others who are also taking care of themselves as we work together as a team to take care of the community.
As soon as we started opening the doors, more and more people wanted to volunteer, and it's fascinating to see how all of a sudden this cumulative energy is moving forward and spreading and helping people to heal. And without them, it would be absolutely impossible.
Oh, I volunteer because it's such an important cause. It's made a huge difference in my life. And I feel that the potential to help other people and feel better in their lives is so important. I don't think that acupuncture is supported enough as it should be. And so I want to do what I can to contributing to making this kind of healing accessible to all people.
So we really see like a wide range of pathologies, of diseases in our clinic. We treat acute chronic pain. We treat digestive disorders, chronic diseases like diabetes, for example. We treat hypertension. We have treated pregnant women, so we do prenatal care. We have done fertility treatments. We also have done end-of-life care. So we really encompass a whole range of diseases and ailments in our clinic.
Our bigger vision of KCAS is that actually KCAS is a public service that the Ministry of Health is funding us with an annual budget, which is not that much considering what we are doing. And I think specifically for rural communities where we don't have the services, it would be like an amazing addition to offer that.
I can see a clinic like this being a benefit as an adjunct to allopathic medicine. It could be a relationship that could benefit the patient and their families and communities.
The longer we are established, more and more people are going to want to receive treatment at these clinics. And the only way that that is going to happen in the long run is with increased funding, whether it be private or public, but it is essential for the health and well-being of the people of this community.
I mean, I think everybody's just doing their own thing in the chairs, but the healers that are here are just so compassionate, and I love them so much. They're wonderful human beings. Yeah, so great.
All right. I hope that was inspiring. And
That was inspiring. So I think Sarah's now having technical issues. So apparently the gremlins are sharing.
okay.
Thank you very much. Oh, there she is.
Oh no, sorry. I'm still here, but I just turned my camera off so that it uses less bandwidth. Yeah. Thank you for sharing that, Lena. You can continue with your presentation.
Thank you so much. So people in rural areas face significant hurdles in accessing quality care. There are geographic barriers, long drives to nearest clinics, especially for specialist appointments. There's a critical provider shortage with a lack of trained professionals in the remote areas. But the most formidable barrier is often the financial one. People don't have enough money. Many rural residents are low income, uninsured, or simply can't afford the high out-of-pocket costs for traditional private practice healthcare. This is where community acupuncture offers a powerful solution. By integrating it into our public health care system, we can eliminate the financial barrier entirely. Patients don't have to worry about sliding scales or co-pays. They could also care as a right, just like visiting a family doctor. The model also addresses the other barriers, like making treatments more effective and efficient. A single practitioner can treat multiple patients or people in a shared space, increasing capacity, lowering fixed costs, and helping to alleviate provider shortage. By bringing publicly funded clinics directly to rural areas, we can also drastically reduce the travel burden on patients. Community acupuncture is not a siloed service. It's a powerful tool for integrating into the public health system. We can work directly with primary care providers to make acupuncture a routine, non-pharmaceutical options for chronic pain management, a major issue in our public healthcare budget. We can collaborate with mental health professionals to offer a supportive, low stigma environment for people dealing with stress, anxiety, depression, or PTSD. And by partnering with existing healthcare units and community organizations like senior centers, youth centers, or local community halls, we can establish publicly funded clinics that are both accessible and trusted within the community. The key to making this work is a fundamental shift in how we view and fund acupuncture. We must, above and beyond, we must move beyond inconsistent, private, insured-based models and make a clear commitment to public funding in these services. This means advocating for policy changes that recognizes acupuncture as an essential part for the public healthcare system, covered under provincial and federal healthcare plans. To ensure long-term sustainability, we must also focus on local capacity building. This isn't just about bringing in practitioners, but it is about investing in communities. Public health funding can be used to support training programs and local apprenticeships, ensuring that rural communities have a human resource to staff and running other programs themselves. This creates a sustainable model that is not dependent on any external aids. To support public health initiatives, we need a robust training strategy. So we should develop and fund training programs for healthcare professionals, such as doctors and healthcare nurses or community health workers, to integrate the basic Chinese medicine principles into the practice. For licensed acupuncturists and practitioners, we create publicly funded scholarships and incentives to encourage them to work in rural settings and offer incentive programs like the doctors and nurses have. And it's like, for example, a student loan forgiveness program, which doesn't exist for Chinese medicine doctors, practitioners, or acupuncturists. Reaching remote population requires creative public outreach. And one of those creative public outreach would be, for example, a mobile acupuncture unit funded by the public health system, and it could travel to isolated communities. We could also utilize existing public health resources to offer education or wellness programs to benefit the Chinese medicine health concept and combine it with Western medicine. The data and patient stories are clear. Community acupuncture works. We have seen patients reducing their reliance on opioids for chronic pain. We have witnessed the significant mental health benefits for those suffering from anxiety, depression, and PTSD. We have seen improvements in digestive dysfunctions and so much more. Integrating this service into our public health system is a win-win. It improves patients' outcome and reduces the long-term cost associated with chronic disease and prescription drug use. In addition, it offers a preventative and a healthcare measures of so it offers a more preventative healthcare measures can offer financial savings for the Ministry of Health as well by reducing visitations to the ER because of preventative care and reducing the pressure on the medical staff in the hospitals. So I ask you all to join me in this call to action, and the action would be for elective officials and policymakers to champion legislation to fully integrate and fund community acupuncture within our public healthcare system, especially in rural communities. I also ask for healthcare leaders to advocate for public funding and infrastructure to support community acupuncture in rural areas, and for stakeholders and community members to rally for this essential service and make it clear that public funding for community acupuncture is a public health priority. So thank you so much for listening. Thank you so much for opening your heart to community acupuncture and Chinese medicine as an not just adjunct, perhaps even a parallel medicine to our healthcare system. And let's work together and make accessible, affordable, and effective healthcare a reality for every single person in our community, in our rural communities. So thank you so much. And I'm just gonna stop sharing here.
Thank you, Leanie. That was wonderful. That's so important. And I'm going to open the floor up to anyone that might have questions for you if you're comfortable with that. And then we'll move on to our next segment, which is we're going to get to hear some of the challenges and opportunities in your communities. But yeah, Ed's got his hand up, and go ahead, Ed.
Thanks so much, Lenny. That's such a great presentation. A really well produced video as well. That was nice to see. A quick question. You mentioned that there's or in the video, I think someone mentioned that there's ways to treat diabetes with acupuncture. And I don't have a medical background myself, it's administrative, but I don't think we have a lot of acupuncture resources on the type 2 diabetes website. I'm just curious what the details are behind that, if there's a summary.
Yeah, great. I mean, acupuncture, I mean, especially with type 2 diabetes, we are looking at lifestyle, right? We are looking at the concept of how can we help people to have more integrity within their body, and by opening meridians, opening the energetic forces within the body, and then coaching them through dietary preferences, as well as recognizing where the gaps in their life. Then also their central nervous system is starting to calm down, and the vagus nerve is more available for digestive functions rather than the sympathetic response. So acupuncture can help tremendously just with the causes of diabetes too, and to like Chinese medicine in general. And then also we have herbs because often with diabetes, I mean, I can give a talk on that, but there's lots. There's honestly a lot that can be done, that can be integrated. And yeah. Does,
Understood. Yeah, thank you very much.
does that make sense?
Yeah, thank you.
Yeah.
Maybe I'll just throw a comment in there. So thank you for the presentation. I think this is really helpful, and it underscores the issues in rural. You've got, I think it's compounded. You have the inability to recruit or retain people that have these unique skill sets. And then if you are able to recruit and retain them, if they're a certain group of practitioners, they're not covered through MSP billing or through government funding. So it's a two-tiered issue. And then when you try hard to get people to deliver services in rural, and then when you actually find them, we don't have a way of paying them. And there is, I think, a fairly large group of practitioners that are in this same space. And I'm thinking about chiropractors, private physios. It's kind of the same issue, and it just keeps coming up over and over and over again. I'm curious about. I'm just thinking, kind of out loud. Maybe there's an opportunity to connect after this meeting with a few suggestions around sort of partnering with some of these other disciplines. The challenge arises also is that there's such a small number of acupuncture practitioners that the voice isn't as loud. So what is partnering with some of these other disciplines who are in exactly that same boat, where we're talking about service to rural communities and that being the priority, and there's a range of disciplines that could benefit from some kind of shift in policy. So maybe there's an opportunity for us to connect after the fact. We could have a little bit of chat about that.
Yeah, I 100% agree with that, Kathleen. This is a big deal. I just came out of a meeting like just 2 weeks ago with our ED of our association, the Association of Traditional Chinese Medicine Practitioners in BC, like what they are trying to advocate for is now to just for low income patients that they have access to more money for supplemental benefits, where the $23 10 times a year was implemented 25 years ago and has never been revisited. So we are trying to push for at least like 20 to 24 treatments per years and up to maybe $60. And that would help us like as at this point a nonprofit organization, a private organization, to bring up the income a little bit, because some of our patients, they have barely enough money to pay for food, right? And so what they do is they donate the $23 10 times a year as a donation to our organization, but they're running out by June because they come every 2 weeks. And so, and that's not cool, right? Like those, especially those patients are, they need more support. They're so vulnerable, and I think it's the same for chiropractors. It's the same for probably massage therapists or for physiotherapists. Yeah, this brings us into this concept of integrative health clinics again, right? Like working together as a team and understanding the pro and cons, and having it more like a patient-centered concept, so that we all can help the patient to come together. And especially when we see like mental health problems, which are just like skyrocketing right now. Like I see it in my clinic, I see it in community acupuncture clinic. Yeah, we need to hold space in a way more integral and better way for our community members. So yeah, I agree with everything you say there, Kathleen. And yes, I'm involved in it as much as I can. And I would love to have a more detailed conversation on that. And Ed, I can be available for you as well if there's something about diabetes too, if you want to get more information out for your clients and for the people that are reaching out to your organization.
Thank
And
you, Lenny. I'll
maybe
post my. Oh, sorry, Sarah. I'll post my email in the chat just so you've got it.
And Leanie, maybe add yours to the chat as well. And I'll just touch base on that. We're in with RCCBC a meeting recently around transportation, and to touch on the fact that Leanie said that the $23 12 times 10 times a year, there are people who are undergoing cancer treatments who are not going due to financial restraints. And so they just said, no, we're gonna, it's more important to make sure there's food on our tables. then we can't afford to get treatment. And that's wrong, right? That's like so sad and heartbreaking in a country like Canada where we're now putting our health aside because the cost of living is so high that we can't actually afford to take care of our health and the outcomes of all of that. So thank you, Lainey. This was great. I'm gonna let we have Dr. Markham, Ray Markham has just joined us, and maybe do you want to give us? I see you added it in. If you missed the presentation on Lainey, if Lainey wanted to just do a quick summary, or we have recorded it. Um, so if there's Ray.
I'll listen to the recording. Sorry, I'm late. I don't want to interrupt the flow. I just wanted to take a chance to listen in for what I could. So my apologies.
No, don't be sorry. So if there's no more questions for Lainey, we'll move on to sharing about some of the challenges and opportunities that might be your community is facing. And Leanie, please share from your perspective for Caslo as well as a resident, that some challenges and opportunities, maybe some success stories. I know Kathleen had this morning had a great way of framing the way that we can talk about this because we don't want to get mired in the negativity, but sometimes there's opportunities to just share with a different perspective of like what's working and what some of the beautiful things that you see that are working versus like we all know what's not working. And but yeah, please feel free to like, and Tony, like we want to hear from you from your perspective as well, from even though you're in Manitoba, it doesn't we still love all to know across the country as well. And same for you, Royce. So would anyone like to start about sharing some challenges or opportunities on rural health in their community?
Well, I can share something if you want me to. So, we just got a new doctor in our community, Dr. Taylor Martin. And this has never happened before in the last 8 years since I've practiced in Caslo, that all of a sudden I have patients that come in and say, actually, I was referred to you by Dr. Taylor Martin. And I love this ability to work together with patients. Number one, for the fact that I don't really know pharmaceuticals too much. I mean, we had a big pharmacology course in our education, but it's not my medicine. And at the same time, we need it. And so I need to network with a medical doctor, a Western medicine doctor, and it's so amazing. It's like it's a new way of expressing um, the medicine in its highest integrity. So I really want to celebrate that.
Thank you, Lainey. That is great. I know Caslo, we're so excited to have new doctors that are permanent. It's not a locum. They're moving here. They're really excited that the recruitment that Interior Health is doing. And just, I think that there's a new vision for a lot of doctors that are they're choosing quality of life. It's not about being exciting and being in the ER in downtown East Side Vancouver. They're choosing like what does life look like for them as a rural doctor? And I'm sure Dr. Markham can speak to that as he's a rural doctor in the north as well. But yeah, is there anyone else that would like to share? Like it can be personal, it can be community based, it can be. I know Royce had some rural health experiences recently, so that whether it was on the island or up north that you had two, you're a lucky guy. But yeah, so if there's anyone else that would like to share, I know Kathleen, you had your hand up. I'm sorry.
I'm just thinking about when you live in a community where you've got a range of populations and you've got, there's younger people in the community and there's older people in the community. And then there's a lot of sort of that mid-range people often will go out to work or leave and go and work in, different environments. And then how are we providing the support in those rural communities? And the reason I say that is I live in a small rural community, and we have a really disproportionately high number of seniors. And I'm watching over the course of these last several years, watching all of my neighbors aging, and we have more neighbors in their 80s than we do in any other age demographic. And there's nothing here for them. There's no home support services. There's no activities of any sort. There isn't really. And winters are harsh. We live, at 1,000 meters elevation, so there's a lot of snow. There's a lot of ice. There aren't kids around to shovel driveways. There's no way of getting HelloFresh or any other type of food delivery services of any sort. We have also, even just as a small community, pulling together to try to talk a little bit about, how do we do that? We do lots of informal, checking in on your neighbors kind of things, watering plants and making sure you see somebody every day and those kinds of little sort of neighborly things. But as that demographic starts to get even older, like people are having to move, they're having to sell their homes, they're having to move out of the community, having to move to cities, which isn't their first choice. So I think, all of the people who are living in rural communities, I mean, I'm not saying anything at all that you haven't already heard and that you're not already experiencing. And I am just curious about whether there is any interest from this group of even thinking or talking at a demographic level. Like we're talking at a generic rural level, but is there any opportunities at all to spend some time through one subsequent meeting focusing on particular demographics? I mean, how you're supporting children who are living in rural communities, but how are we supporting seniors that are living in rural communities? I think there's an opportunity that collective wisdom of this group may be able to come up with a few ideas that maybe would be worthwhile sharing across everybody, or we put our collective brains together and we can come up with a couple of strategies that actually may be helpful at the community level. So it's just a thought.
Yeah, thank you, Kathleen. That is so true. We are, as most rural communities, the demographic for most rural communities is plus 56, right? Caslo is actually one of the oldest municipalities, like age-wise, but it's growing. But at the same time, the underlie of young families coming in with young children, and that's happening in rural communities as well. So it's great. And Pablita's in hospice, so she knows exactly about what it's like to be working in that. It's not everyone is old that is in hospice, but it's like that, the seeing the change of people come in and go, the demographics, that's that as well. And so was there anyone else that would like to share their community? Or the other thing we can talk about, oh yes, please go ahead, Trisha.
There and unlocked. So I live just outside the community of Lytton. So we have a number of challenges. Leni, sorry. I think that acupuncture thing would be really cool to know more about because there has been a lot of trauma in the community. We've had challenges in that we lost our healthcare center in 2021 during the Lytton Creek wildfire. Um, Lots of people lost their homes. We've had a number of the older population that have had to actually move out of the community because we don't have healthcare or reliable healthcare, and we don't know exactly when we're going to get it back. On a positive note, what I should mention about this, because with every negative there is a positive, is that actually 6 of the local First Nations bands, um, the mayor of Lytton and myself as the area director, we've actually formed a group thanks to the chief at Kanaka Bar, and we're trying to meet with Interior Health and with some of the healthcare providers to see what we can do for the community. So in some ways, well, it's been a heck of a challenge. We are coming together as a community to try to find solutions. And we have been fortunate enough to now have a pharmacy that is set up in a trailer on Lytton First Nations, but it is slowly happening as we work together. It's so slow.
And to talk about resiliency, rural and resiliency, they often get put together as one term. And the people of Lytton and the surrounding community, considering it's been 4 years now, plus that since the fire, and you're still in that rebuild, big question mark phase, but the resiliency of the people that call that home is so empowering. It's so inspiring to see that and to working together. I think there's 5 nations or 7 nations around your community.
6.
6, yeah. So
There's
that's
Cook Ferry, Kanaka Bar, Nikamin, Scuppa, Siska, and Lytton First Nations.
yeah. And so that adds a whole other community building piece to it. That's really beautiful to see the collaboration coming together to for ultimate goal of making this a place for everyone to live. Hi, Lini, your hand's up.
Yeah, Trisha, thanks for sharing. That's incredible. And I really resonate with it because of the wildfire we had north of Caslow. And the cool thing about having had community acupuncture already established was that we could mobilize within 24 hours to set up community acupuncture at the church and treat patients right away who have been in shock. I mean, it was fascinating to see people coming in. My finger hurts, and I just know that they went through this enormous, enormous fire shock, and you start unwinding, and all of a sudden they could release and they could sleep better, they didn't have nightmares anymore, they could digest better. And all we did was like simple oracle acupuncture. It was like really not rocket science. It's something a nurse can do, anybody could do, right? And I think that if we can start community acupuncture um, also as a first response mechanism, that would be fantastic. It would be so, so, so good. And then, of course, PTSD, that's the other thing that we are working on right now. These patients are coming to our clinic and they are monitored, right? They're cared for and they're yeah, yeah, and it's the model itself is honestly so simple. It's really not complicated at all. At all. All you need is some cool recliner chairs, somebody who does admin, a few blankets, and an acupuncturist or a Chinese medicine doctor. It's very simple, and I'm more than happy to talk with you about it and see if we can do something in Lytton. It would be fantastic.
Thank you, Leni. I love this. I love the collaboration, and that's what one of the rule is not just resilient, collaboration is key because we all live in our silo and try to recreate the wheel for everything, not knowing that what's working in Caslow could be a template for another community. It's just so wonderful, but we don't know what we don't know. So that knowing's half the battle. And here we are sharing. So please take this and go. I know Trisha sits on many boards and she's really involved in lots of things to do with rural and elected officials. So if you hear something in one of your meetings you're at FCM or UBCM and this resonates with you, please by all means share it. I'll send the link out to the recording. I did tell our morning group that I do have to go downtown at 11 p.m. tonight to upload this because otherwise it takes 24 hours to upload anything on my terrible Wi-Fi. So I will be down using the fiber in downtown tonight, leave my laptop in my car and walk home and go to upload. Yes, go ahead, Leni.
Um, I just want to tell everybody that I have to leave because I have a patient in 15 minutes. And I just want to say quickly thank you for having me here. And also, I would like to offer that if I can be of any help to any of you, I'm there. I'm there. Just email me if it has to be a Zoom conversation, like with one of your boards or with your community, with organizations. I'm more than happy to offer what we do in Caslow, and so we can have as many community acupuncture clinics all over Canada. That would be amazing. All right. Thank you so much, everybody.
Thank you. Thank you, Ed, as well for joining. We look forward to seeing you in October. Yeah. And thank you again, Leni. Wonderful. That's great. So this has been a fantastic meeting. Our last item on the agenda was sort of to talk about what do you see yourself as, what's your role in rural health? And I know that with the few of us here, we can either give us all a quick my role in rural health is, or everyone could have a half hour free. So of course we want the first, but um, I know that for myself, my role in rural health is I really love facilitating these opportunities, meeting with people like Leni who are so passionate about rural health, talking to the new doctor in town who is just so excited to be here, talking with our local hospice that are like working to be like, this is what we're doing, and they're passionate about it. And I'm off to Kelowna this afternoon to go to talk about rural housing with the Minister of Housing critic and how housing is a direct correlation to health. That kids who are unable, their housing is unstable. If you have unstable housing, that affects your health. Your mom and dad don't know if they're staying where they're at, and you're like all of the pieces and how it all fits together so that we all have our hands in rural health. And because we're rural, we also know transportation is key. So when we think about how long it takes for us to drive to the hospital or walk or hop on transit, there's somebody who lives 2 hours up a dirt road and that's their hobby farm and it's their dream place, and they're on dialysis and the closest dialysis is so far. And what does that look like? Or they just want to have a telehealth with somebody. So we all have play a role in rural health, and what that looks like is up to us. But being able to really empower each other and just know that we can emit the change. Like I love Kathleen is a what's the outcome of this? What are we going to do? And she always circles us back to like what can be done. What is the takeaway? What is something that we can say solution based in the end? And it's just so refreshing. So we can all sit here and talk about things, but at the end of the day, what can we do? And that's just so nice to hear. I'll let anybody else like to go.
Oh, Kathleen, I don't think your volume's working.
No, and I got my phone on my little microphone on mute here. Sorry about that. I think I love this kind of conversation because we've never met more people who are more creative and more resilient than people working in healthcare in rural. So I have a healthcare background, so not everybody's, from healthcare, but the idea about health of populations is healthcare, but there's also other components to it that contribute to the overall health of the population. And I always think about things like, so I worked in interior health for a number of years. I worked in Fraser Health for a number of years. So I've been, around in a lot of the rural scenes and the really rural and remote areas of the province, and how the communities take care of each other when there's no community resources at all, and how people manage and take care of things. And I wonder, this, Sarah, what you think about it. I mean, this table could be that place. It could be a repository for brilliant ideas. What are the brilliant ideas that you've seen working in your communities that you think that we should be sharing and telling everybody else about? Because I do believe that there are a lot of them. There are things that kind of, I'm thinking about something like there's a home at this is in a rural Ontario community, but it's still from there as well. And I worked rural over there as well. Rural Ontario community, they had a program called Home at Last. And you think about somebody who is discharged from the hospital and they ended up with a handful of physician's orders and a prescription, and they ended up going back home to their community. And then, shortly, 6 days later, they've had another health challenge, and they're readmitted to the hospital. And then we do the sort of the diagnostic on it to understand why the person had a prescription for a medication change, but the medications never got picked up. There was a follow-up order for the physician for that person to see their doctor, but they didn't make the appointment, or they didn't have a doctor. So there's a number of things that happen, and just as just one example around hospital readmissions, and a small community that put some things in place to make sure that anybody coming back to the community discharged from a hospital in a larger center, that there were people with eyes on. There was a home support worker who went to visit that person within a couple of hours of them coming home, and they had a conversation about it. They looked at the paperwork that came with the person. They cleaned out all the old rotten food out of their fridge and threw the food in the garbage, and went to the store and got some vegetables and made a pot of soup. And like there's things like that are really interesting, creative things that could come to a table like this to be able to share for packaging and redistribution, that maybe give other communities other ideas about things that we could do to help the health of the population.
That's wonderful, Kathleen. See, she always comes up with these things like, this is what we can do. Roll up your sleeves. Let's go. And it's great so that because we really can have things done. And idea sharing is one of those things which doesn't actually require us to, because we all are probably working off the side of our desk to be in this meeting. And then what do we do? How do we add more to our table? And but there are little things, and even just that, as much as like coming in and sharing ideas. And yeah, I'll stop talking so Pablita can talk.
Hi, everyone. Um, so just to kind of answer your question around, what can we be doing? What roles do we play? So there's two areas that we've been working on. So for those that don't know, my name is Poblita. I'm the ED of the BC Hospice Palliative Care Association, and we advocate, educate, and train and bring awareness to hospice, palliative care, and grief and bereavement in our province and nationally as well. Um, so I actually also sit on the Caribbean Palliative Care Association. So this is actually the lens that I'm going to bring in for a second, just to help with the rural and remote conversations. And so because of that, I'm part of the Americas World Health Organization. And so there's two parts. There's the policy advocacy piece, and then there's the example of something that's working in different regions that I'm thinking we maybe could talk about. But advocacy I advocate. I can advocate for a dog if a dog's on the street and I'm seeing like it advocating is to my core. And so the World Health Organization just came out with a new ranking of a framework, a global framework around palliative care and where Canada ranks. The reason why I'm bringing this up to this group is because there were 14 indicators across 6 domains that looked at on a global scale where Canada ranks for palliative end of life care. And the six domains were around policy, essential medicine, service delivery, education, and research. And so I was wearing my Caribbean Palliative Care Association hat when I was filling out this global ranking for the Anglophone Caribbean islands. And so I was able to get preview of where Canada ranked. Canada didn't do too good because so Canada is ranked under the established section. Um, there's three subcores, and palliative care is an established framework in our country, but it was ranked 52nd globally, eight in the Americas. That's not actually very good at all. Where it ranked really well is medicines, of course. We have good access to opioids, essential medications, makes sense. Education and training, hell yeah. We have awesome clinical training, practice of care, um, norms of practice. We are a country based on education and training when it comes to our clinical teams. Research, okay. But where we ranked really poorly in was in policy integration from someone that works in policy work. Yes. But service delivery where? It was access to rural and remote community and indigenous communities underserved. Why I say this is horrible is because when we look at the Americas, countries like Costa Rica, Bolivia beat us in rural access to service delivery. So I'm in the midst with my team to blast this report because now I can because it's public. But I think there is something to be told and something to be said that for Canada, that has great clinical teams and supports, that has opportunities to expand in certain communities like Indigenous and rural communities. Globally, we are even ranking poorly in something like palliative and end of life supports. Kathleen, this kind of comes back to like when you talk about services and supports and things for seniors to do. When we look at hospice palliative care, it is very volunteer led. So a lot of the volunteers are seniors. But what we're starting to run into the trouble of is that um, getting even a volunteer coordinator to train hospice volunteers is an issue. And when we look at rural and remote communities, getting a hospice house is not going to happen. A residential hospice is not going to happen. We don't have the population. So organizations, there's a Six Nations in Ontario where they've deployed um, volunteers, elders, community leaders in communities, both Indigenous and non-Indigenous communities, to support palliative care services. That is where the future is or lies in that type of service delivery models for rural and remote. But I guess why I'm bringing up this report is because it clearly shows that our service deliveries, when it comes to access to rural and remote and indigenous communities, are no longer, we can no longer say it's patchy. We just, it's non-existent. There aren't services that reflect the needs. So, on an advocacy level, the association is going to be bringing this into the mix of our reports to highlight the international, the national, and the provincial and regional aspects. On a local level, United Way has done a great job in getting funding from the Aging Dignity funding that was provided by the federal government on the bilateral agreement. And they've started to really expand in rural and remote communities to partner with hospices, but other organizations that are somewhat established but need funding to kind of come together and provide more services. Maybe if this group is inclined, there might be an opportunity to have the director of that division come and speak to this group because they're not only opening it up funding to their organizations that they usually fund, they're actually trying to open up a little bit more into communities that don't have any services for seniors because that's their portfolio of seniors. So maybe there's an opportunity for that as well. So that was just my 2 bits.
Fabulous, fabulous information, Pablita. I think that's really, these are the kinds of things that, highlight an issue. And we, what about taking it to that next level, which is kind of my thing that I like to do, which is, okay, what are we going to do about it? Or is there something we can use here? Is there something that we could do here? I mean, the concept that I do like when we've got a community that doesn't have any services, it's not necessary to build a whole infrastructure. It's about finding existing infrastructure and tucking up something that requires some education and some support underneath that, and really sort of stretching the administrative structures in order to provide the supports to be able to deliver a service. And when we think about things like First Nations, we've got some cultural importance that needs to be managed. There's some expertise at the local community, but the resources don't exist. This is absolutely brilliant. I think this is a great idea. Sorry, Tony, I realized that I just sort of answered her question without acknowledging the fact that you have your hand up. So I step back, hand that over to you.
No worries. It's all good. I found that interesting, Pablita, and I love the reference to the study that you've seen. Um, I would ask what we can learn from those other nations that economically probably are far less developed than Canada. I think you stated that. But what can we learn from them if they are seeing the same issues in those same communities? How can they outperform a country like Canada? What is it that they do that we can learn to do? And I would love to know the answer to that question. So how are they doing that? And then um, yeah, I'm just going to leave it there. That's the question I would ask is what are they doing that we can learn? Because obviously we have all of the infrastructure, the training, all those great things you just mentioned, but we're not doing something. What is that? What does it look like? How are they implementing, et cetera? So I don't know if you have those answers, but I'd be very, very interested in hearing about that.
I don't in full have the answers to that, but in conversating with some of the other countries, like Mexico, like Uruguay, even some of the Caribbean countries, what I've noticed is that in Canada, I think what ties us in our healthcare model is that, and I am saying this with as most respect possibly at the same time.
Understood.
Our clinicians, because I am also clinically trained as a physician, I know the hurdles and there is a level of limitations of things that you can and cannot do when it comes to liability. And also there's so many practice of norms. There's so many policy integrations within our healthcare system. It is sometimes very difficult to kind of get around that. But in saying that, I think these other countries have been able to master that they know they cannot depend on their government or policy systems to deliver community supports. So they've really come together and build infrastructures that can allow them to support their communities the best that they can, and then coming to government or other organizations that can fund them, because a lot of them, there is a level of um, local indigenous community lens that speaks to this type of community effect. Um, so they really just take it amongst themselves. Now, mind you, when we think about who is reporting back, in terms of who are they consulting for these types of reports, they are a lot of the time consulting physicians, researchers, or professors within those um, countries. But in those countries, even the professors and the medical teams understand the level of community engagement and community lead that they actually have to consult them in order for the information to be presented. So it is very much more um, cross-learning. I think, and I know that there is a bit of challenge in Canada is that I feel that sometimes our community care supports can't really speak kindly or can't really integrate well with our primary healthcare systems. And I think people fall through the cracks in rural and remote. From what I'm noticing from even the data that we're seeing, is that those cracks are even so much more large. You know, they're bigger, and they're having to fill. So I do think things are going to be things have to be done differently in rural and remote. I know we say that all the time, but in essence it has to be, because the models that we have right now, even when we talk about funding or program services in rural and remote community, we see them in a hospice lens. We can't even do it in some of our rural communities. It just the population approach, the numbers, who's accessing what, it doesn't work. And I think these other countries have seen that and they're understanding how to navigate it the best they can.
So I'm just going to follow on. So I'm hearing, I've had conversations with a number of other individuals in British Columbia, and one of the areas that they focused on is the rural, remote, indigenous. And one of the folks I'm speaking with went as far as to say, we're going to do it different in those communities because people just realize without doing it different, you can't deliver it. And I
Mm,
think you mentioned liability, medical legal issues, all of these things, practice standards, et cetera. I'm speaking to someone in Manitoba right now. She is an EMT, and she is now back at school at Red River Polytechnic, expanding the scope of her practice because the Manitoba government has realized there's no way to deliver the care that they need in rural and remote communities without relying on other practitioners, people who care, people who love, people who support, people who are active in care and healthcare, haven't gone to med school or taken the next degree, but they're creating the space for them to come back and at distance, and both local and at distance, get trained, expand. They've already got a good basis of knowledge. Now let's build on that. Let's build on that. That's also being spoken about in Alberta in specialty areas like cancer, where they're saying a general oncologist located in Grand Prairie, Alberta, may want to do more things because we need him or her to do that. Let us
mhm,
create the space, that educational space to get them engaged. They're there, they live in the community, they're engaged in the community, they're in care. So I'm thinking that if you're an advocate, you said you're an advocate, advocate for these types of practice changes, not without hurly-burly, off the cuff, but rather
right.
in a metered fashion, and allow those people who want to be in the care process to be in the care process, to take on more responsibility with the full backing via technology, et cetera. Dr. Markham's a phone call away, a telehealth link away. Ivor Mendez in Saskatchewan, he's driving his little robot around in rural communities. He's there hand in hand. We have remote sensors and monitors. I know these things cost money. I'm not suggesting it's easy. But if you're going to advocate for people who are already in community, who are so interested in being involved more. Give them the skills, give them the tools, let them take on more. They want to. That's all I'm going to
Mhm,
say. That's my passionate plea.
agreed.
Thank you so much. That's perfect. I love that. And with that, I love the passion. And I think we'll just, if there's no other final comments from anyone, I think that we'll do our wrap up. We've got, thank you, Pablita, for putting that in there. Our next meeting is going to be November 18th from 2 to 3:30, same time. We've got some guest speakers lined up for virtual health. And if you have someone that you think, Tony, I know you just mentioned drop some names there. If there's somebody that you would think that would be that could have a 15 to 20-minute presentation that would benefit the group to hear some solutions or perspectives on virtual health in rural and remote and First Nations communities across the province or outside the province. It's nice to hear what people are doing outside of BC as well. Please send me their information. I will send you all, if you would prefer a calendar link versus adding it to your own calendar, I can send you all.
Yes, please.
Yeah. I know. I said this morning, I was like, this is in my calendar. What do you mean it's not in everybody else's calendar? So I will add it all. I will do that as soon as I hang up. But this has been so wonderful. And for me is I know we always hope for like 50 people in these calls, but sometimes these intimate groups, we really get to share and have a great, meaningful conversation. And I'm glad you were able to join us, Trisha. I hope you're able to join us again and that this is your first one. And I think you found value in here. I hope you found value being with us today.
Tremendous value. Thank you.
Awesome.
I really appreciate the addition. Thank you.
Yeah. And is there any final thoughts from anyone else that would on today's call or on what we should speak to next time? So I'm just copying this from the multitasking. Awesome. Well, thank you again for that. Thank you very much. Thank you, RCCBC, for allowing us to facilitate this role with Kathleen and I co-hosting. We love the link sectors and the partnership. Pentagram Plus is such a valuable tool for all of rural and remote healthcare across the province. So it's great. Enjoy the rest of your week. And you've got my contact and Kathleen's contact. So we look forward to hearing from you and seeing you in November.
Thank
Thank
you
you
all.
all.
Cheers.
And check your mail for those buttons, Trisha.
Thanks, everyone.
Thank you.
Thanks, everyone.
Take care.
Bye-bye.
Bye-bye.